So good afternoon, everybody, and welcome to today's President Speaker Series event. I'm Dr. François Belanger, Vice President of Quality and Chief Medical Officer, and I'm here on behalf of Dr. Yu, our President and CEO, who is listening from Edmonton and obviously snowbound as other people are today. So thanks for joining us on your lunch break. I'd like to acknowledge that we've gathered today on Treaty 7, Métis Region 3 territory, and a traditional meeting place and home for many Indigenous peoples. I'd also like to thank our hosts here at South Health Campus, as well as our telehealth staff, for setting up today's presentation. There's a lot of work done behind the scenes to make this event happen, and we couldn't do it without your folks. Also, this event is being recorded, so if you're listening in on the phone line, you'll be able to watch the full presentation at a later date. We've got more than 50 sites that are tuned in from all over the province today, and we'll have 15 minutes for questions and answers following today's presentation. For those who are not at South Health Campus today, you can email your questions to pss@ahs.ca. That's pss@ahs.ca. We'll try to answer as many questions as we can before we run out of time. And no matter where you are watching us from, you're in store for another outstanding presentation and discussion. And we're really excited to have Dr. Brent James as our keynote speaker today. The President Speaker Series brings together staff, physicians, international experts, and innovators to discuss ideas, advancements, and strategies around healthcare. It's a chance for us to learn from others, leading thinkers in healthcare across the globe, and adapt their ideas to how we deliver care. Dr. James is one of those experts. He's part of the Masters of Healthcare Administration faculty at the David Eccles School of Business at the University of Utah. He's also, on this topic today, he'll speak to why clinical quality management should be a core focus. And he'll discuss how data is clinical in improving quality of care and keeping the cost of treatment down. Dr. James also served for more than 30 years as a Chief Quality Officer and Executive Director of the Institute of Healthcare Delivery Research at Intermountain Healthcare in Salt Lake City. In that role, he trained more than 5,000 senior physician, nursing, and administrative executives from around the world, including our own, in clinical management methods. He's also helped launch and support more than 50 sister training programs in more than 10 countries. As you can imagine, he's been honored with many awards for quality in healthcare delivery. He was named amongst the 100 most powerful people in healthcare by Modern Healthcare magazine 5 separate times, as well as one of its top 25 clinical informaticists in 2011. Dr. James has been and remains a champion for standardizing clinical care through collecting and analyzing data on a variety of treatment protocols and care processes and driving quality improvement. So we're really grateful for Dr. James for traveling here to share his thoughts and experiences with all of us. As you know, AHS collects a huge amount of clinical information every day, and we're on the way to do this better through Connect Care. Connect Care is the bridge between information, healthcare teams, patients, and the future. And the foundation of Connect Care is a common clinical information system that will allow healthcare providers a central access point to patient information, common clinical standards, and best healthcare practices. Connect Care involves other work such as supporting consistent clinical care practices across the province and will enable staff and physicians to utilize online and electronic tools to better support clinical decision making. However, this is about quality, this is about health outcomes, and this is about Albertans that will expect the healthcare system to provide timely access, value for money, and a high quality patient experience. So without further ado, I'd like to welcome Dr. James, and I know he has a really captivating presentation for you. So welcome.
Thank you very much, and good afternoon. It's a true delight to be with you. This story really starts back in 1986. Oh, okay. I better stand really close here then. I thought I got some freedom. Okay, good. Story really starts back in 1986. I was a professor in the Department of Biostatistics at the Harvard School of Public Health. My clinical appointment was at the Dana-Farber Cancer Institute. I was a fairly classic academic physician, part of the largest multi-center trials group in the world. Eastern Cooperative Group had about 450 contributing hospitals scattered around the planet. At any given point in time, we had about 100 randomized controlled trials running. That's where I really got my start. I was over GI tumors. At any given point in time, I'd have somewhere between about 4 and 8 trials for which I was responsible. Altogether, this was back in 1986. We were about a $200 million operation doing studies of new cancer therapies. In theory, it was a clinical appointment, but frankly, I just did research, randomized controlled trial research. It all changed in 1986. I suddenly, quite unexpectedly, became a single parent, and it was just me and my 3-year-old. I moved back to Utah, really to get closer to family, for help with my son. I joined Intermountain. You know, it's funny, though. As an academic physician, I didn't know that administration existed. I really didn't. I'd trained in surgical oncology, and when I needed them, the resources just appeared, kind of magically, as they should, I should say in passing. I was quite chagrined to learn a few months later that I was the 3rd physician in Intermountain's administrative ranks. I fell in with a fellow named Steve Busboom. He was the vice president for finance, a unique experience for both of us, I should say. Yeah, Busboom had built one of the world's first what's called an activity-based costing system. But somewhere along the line, he had developed an interest in variation in care. At the time, the field was relatively new. Jack Wennberg published his seminal article in the journal Science in 1973, but it was still just a nascent science, slowly growing. Jack, of course, had looked at geographic variation. He'd shown that where you lived or who you went to see was more important than whether you had insurance in determining the actual care you would receive. In doing that, Jack had shown truly massive variation in geographic areas across the United States, across Canada, and across Europe. Interestingly enough, this was endemic in modern medicine. He broke out just major academic centers showed similar variation, and it was profound. It was startling, to say the least. When I came to Intermountain, the way I thought about it looking back, I was trained to do research, and it was the funniest thing. I was of two minds, I guess. I was kind of schizophrenic. When I was doing research, I had a set of rigorous tools that I used, rigorous methods to get strong causal inference. But interestingly, when I left my research setting and went to take care of patients as a physician, it's as if I were in an entirely different world. It was high-quality care because these hands delivered it. I was the fellow, because of my publication history and my institutional association, that when the National Cancer Institute wanted to form consensus committees around GI tumors, I was routinely invited as a national, international authority on that class of disease. And that was our definition of quality of care. It was a model of personal excellence, tightly tied to academic production, frankly. What happened when I showed up at Intermountain, Steve Busboom asked a very important question. He said, we understand that there's geographic variation. He said, I wonder if it extends down to the level of actual patient care in individual hospitals. That was his idea. The way I came to see it is what we did is we took those rigorous tools of clinical research and swung that spotlight over to shine on care delivery performance. We called them QUE studies. In a 2-year time period, we studied 6 clinical areas: transurethral prostatectomy, gallbladder surgery, artificial hip joints, bypass graft surgery of the heart, permanent pacemakers, and community-acquired pneumonia. Short version, we identified every patient who received one of those treatments on a fixed time period, typically a year. We checked to be certain that the medical science hadn't changed over that time period. For each patient, we individually assessed the severity of their presenting symptoms around their primary disease. We identified and individually assessed every comorbid illness. We identified any complication that occurred, individually assessed each and staged it. We tracked long-term outcomes. But we were able to form cohorts of patients that were statistically identical coming in and identical going out. That was the whole aim. We argued that in that framing, it was fair to say, okay, what happened in the middle? To go hunting for variation. all right? I believe, this is just a belief, but looking back and having lived it for years, it's probably the most rigorous approach ever done for this particular question. We were thorough in doing it. Short version, what we found was truly massive variation. Just to illustrate, on the first thing we studied, transurethral prostatectomy, these are two factors our urologic surgeons had identified as essential when performing that procedure. 16 high-volume surgeons, the low-volume people I analyzed separately. So these were people who did lots of these cases, are true local experts, you see. Yeah, the little green squares on this slide show true surgical cut time. Surgeons didn't want to be held accountable for the anesthesiologists or for the nursing staff in the OR, the turnover times. We measured from when they inserted their resecting uroscope and started to cut to when they pulled it and said they were done. The little red circles are grams of prostatic tissue removed. That's the purpose of the procedure, to restore urine flow in people with urinary output obstruction from benign prostatic hypertrophy. Just to give you a sense of the variation, physicians H and F are high in terms of procedure time, 90 minutes per case. The lowest, physician K, 38 minutes. That's more than a 2.5-fold variation across 16 surgeons. Grams of tissue runs from a low of 13 grams with physician G to a high of 42 grams with physician J. That's more than a 3-fold difference. By the way, this was far from the extremes of the variability. What we found was truly dramatic variation using credible data within single facilities. It turns out, in fact, that having summarized it more recently, I'm a member in the U.S. of something called the National Academy of Medicine. We had a mandate from the U.S. government to study geographic variation. The highest rate of variation that you'll find is within hospitals, within a single hospital. By the time you bump to a medical community, you're averaging, and the amount of apparent variation declines. By the time you bump to what's called a medical service area, it declines again. By the time you get to the level of a province, it declines yet again, because at each stage you average, you see. Most of the variation, wild on the hoof, red in tooth and claw, down at the level of an individual hospital, within an individual facility. I need to say in passing too, as a physician, I get to pick on physicians a bit. The amount of variation we found in nursing services was higher than that we found among physicians. The highest rate of variation I've ever measured, having spent a career measuring variation in care delivery, is physical therapy, just in passing. So of the things that I'm discussing, don't think it's just the physicians. It's not. This is endemic across the healing professions on a broad scale. Oh, Busboom had that activity-based costing system that was part of this study. It means you can very accurately measure true cost. Of the 90 factors, roughly, that we were tracking for transurethral prostatectomy, about 45 of them had a cost associated. Pulled those out and then summarized them. It shows the true cost to the facility for performing those procedures. Physician M was lowest. Now remember, this is old data, 1986 data. $1,164 hospital dollars to get a good outcome on a standard case, not counting professional fees, the physician income. The high was physician H, $2,233. Same patient, same outcome, twice as much resource, best we could tell. And that 2-fold variation maintained fairly consistently across all 6 clinical areas. In any area, we typically saw about a 2-fold variation in total cost of care. See that idea? Yeah, implication. When you just look at geographic variation or within hospital variation, who you see is what you get. It raises the issue on the evidence of applying tight research methods to quality of care. It appears that the healing professions are clueless about what actually works. It was deeply professionally troubling. Now, this is a list that I prepared for the Senate Finance Committee in the U.S. government. They're the Committee of Record Setting Health Policy for the United States. It was a run-up to the ACA. I was asked to testify twice to Senate Finance, once to Health, Education, Labor, and Pensions. That was Ted Kennedy's committee at the time in the Senate. Once to the money guys on the House of Representatives side, Ways and Means. I was trying to summarize a massive literature for them. At the time, if you did a Medline search looking for articles in the peer-reviewed medical literature documenting variation in care, you would roll out more than 40,000 articles. Massive documentation. Amazingly consistent in findings. Well, I was trying to break it apart so that these folks in government could understand it a bit. And I broke it into 5 categories. So this is the actual slide I used for Senate Finance. And I wanted to run through it quickly. We really hit on the top one, variation in clinical practice. Again, the professional challenge, it implies that even with full insurance, full access to care, gold card insurance, no queues, it turns out that there's real question that everybody's getting good care. In fact, the variation was so high that was pretty much physically impossible. Now that led to a second question, number 2 on the list. If I had a poster child for this, it would be Bob Brook, Chief Medical Officer at RAND, and Senior Professor of Internal Medicine at UCLA. He said, perhaps we can explain geographic variation through something called inappropriate care. Care is judged inappropriate, clinically inappropriate, if the risk inherent in the treatment outweighs any potential clinical benefit to the patient. This in professions that hold as our primary maxim, first do no harm. These would be areas where we put patients actively in harm's way. Well, they develop formal methods for assessing this. They apply them. 2 major findings from this body of research, again, a whole series of studies. The first, it turns out that inappropriate care does not explain geographic variation. I know right here in Alberta, you show very high geographic variation, by the way, right here, just within this province. But if your results mimicked ours and we used inappropriate care, if we go into a high utilization community for a particular treatment, assess the proportion of care clinically inappropriate, we go into a low utilization community, the proportion of care judged clinically inappropriate will be about the same. Turns out there was no association between inappropriate care and geographic variation. Implication, we're as likely to undertreat as to overtreat, is what the implication is, by the way. Well, secondary finding in this body of research, much more deeply troubling. In that initial set of studies, the high water mark was carotid endarterectomy. 32% of all cases taken to surgery judged to be clinically inappropriate on careful review by one's peers. The risk of the treatment outweighed any potential benefit. It should never have been undertaken. It actually gets worse. Courage trial in cardiovascular medicine estimated that about half of all cardiac stenting to restore blood flow to the heart, 50% clinically inappropriate. The risks outweigh the benefits, but people did it anyway. Nobody's done a careful synthesis across the field, a guess, but an informed guess. Educated guess is one familiar with that literature. About 20 to 25% of everything we do in care delivery is clinically inappropriate. The risk outweighs the benefit. We shouldn't do it. We do it anyway. Oh, by the way, it costs money. It costs money for the initial treatment, and then as you do harm, it costs money to address the harm that you've created. So it's kind of a twofer along the way. Well, number 3 on the list, November 30th, 1999, Institute of Medicine down in the States publishes a report called The Air is Human. That's where we estimated in the U.S. 44,000, 98,000 preventable deaths each year, where the cause of death was not the patient's underlying disease, it was deaths in hospital. The cause of death was the treatments we'd use to address that disease in a way that for each case, 2 independent physician reviewers judged that death was avoidable. We knew we were being conservative. My name's on that report. We've done a full evidence review. We knew we were being conservative. The real toll is about 210,000 deaths per year. Subsequent research demonstrated. Oh, by the way, the person I personally worked with up here, when you measured that in Canada, was Peter Norton. There were others involved. You have the same rates of care-associated injuries in hospitals. Just in passing, it means that hospitals are somewhere between the 2nd and 4th most common cause of preventable death in both of our societies. And this one kind of has karmic balance. You have to love this one. The idea of a hospital as a major public health problem, because technically we are. Yeah, there you go. Now you realize as I that the upside from care delivery is dramatically higher than the downside. Net of this, care delivery adds about 3.5 to 7 years of life expectancy on average to every member of our societies. That's on average. For some people, dramatically higher, for most not so much. but we routinely achieve miracles. That's net of this, The frustrating part, we published that and we spent the next 10 years arguing in the medical profession about how many people we were killing. I swear, nobody ever reads the second half. Well, anything beyond the executive summary of an IOM report, except those who write it. The whole point, we had proven science by which we could dramatically drop that toll. We were cutting those injury rates by 70, sometimes 80%. We didn't have to pay with those lives. That was the point. I don't know how to make it perfect. I don't think anybody really does. The goal is always 0. That's the only appropriate goal. But we could have been dramatically better. Now, number 4 on the list is actually a twist on number 3, a follow-on IOM committee. We called number 3 patient safety injuries of commission where the care actively harmed. We were able to identify, though, areas of medicine where we had proven therapies that we knew worked. Strong level 1 randomized controlled trial evidence, we knew it worked. They tend to be non-controversial. We all agree it should happen. And someone asks the question, okay, for things we know work, how well do we deploy? The best work was done by Beth McGlynn at RAND. She found that for adults, we did it correctly 54.9% of the time, for children, 46% of the time. That's interesting. Well, wait a minute. It's easy to make the case that we fairly routinely achieve miracles. We really do in care delivery, that we're a massive social benefit. But the way to ask the question, if we can achieve miracles doing it correctly roughly half the time, what kind of miracles could we get if we did it correctly all the time, or something close to all the time? That's what that number 4 is really raising as an issue. We call it high reliability. The ability to execute consistently around things that we know for a fact works. You see? Now, if you take the top 4, it drives waste in the system. Using Deming's models and then finding these areas where you have process failures in large categories. We studied that, again, in 2010, another expert panel convened by the Institute of Medicine. We studied it together. Short version of our conclusion, a minimum of 30% and probably over 50% of all resources spent on healthcare delivery is waste, non-value adding from a patient's perspective. I'm most familiar with it down in the United States, of course, where I work every day. Best I can tell, it's the same for you. The reason is those categories that we had up above, that's the sources of the waste. And most of the research is done in the United States. We tend to invest much more heavily in that, but I have sufficient evidence from Canada and across Europe, Australia, Singapore, to defend a statement that it's similar across modern medicine. All right? The right way to think about this, again, it's easy to make the case that care delivery today is the best the world has ever seen in both our countries. The right way to think about it is a list of opportunities. The takeaway, we could be dramatically better. And that's the challenge, that's the task. Deming demonstrated, he basically proved it mathematically, then we showed it empirically in real practice. The best way to control a budget is to deliver better care. Seriously. It's a causal linkage, a hard causal mechanism. And we've been able to show it working in theory and then in practice on a broad scale. I don't know, are you under budgetary pressures in Alberta right now relative to healthcare? Now, it takes lead time and it takes investment. But the right way to manage that budget problem is to dramatically improve our level of care. It's a crazy thing. The best way to approach it that I've seen are those waste models. Now, having said that, I want to turn direction just a little bit, if I may. I just want to shift a little bit. Back when we did the QUE studies, we got some secondary learnings. So see that graph? If you look at that, you'd think that the best physician was M. You'd think the worst was H, at least relative to budget, right? It lines up fairly well with the clinical stuff as well. But here's the funny thing. Yeah, when we examined the detailed data, there was not a single instance where one physician was consistently good or consistently bad. Physician M on that slide, the guy who's so low, on average, he was very efficient. Trouble was, on 2 or 3 things, he was the highest in the group. H, who appears to be so high, on average, he was a fairly heavy utilizer. He had a couple of things where he was the best guy in the group. And if you decided that your interest was best care, it quickly became very apparent that it wasn't a matter of choosing the best surgeon. Now that's a really interesting statement, all right? But it required that you examine the data carefully and thoughtfully, without preconceptions. Best care was scattered across the group. The way we say this now at IHI in Boston, all teach, all learn. Everybody had a little something to teach. Everybody has something to learn if your interest was best care. And what we quickly learned is the key factor for change was engagement. What I wanted to talk about just a little bit was how you drive change and get a couple of concepts on the table to help with that idea. In quality theory, we talk about two uses of data. Again, think of using these data that I just showed you from the QUE studies. How would you use them to drive change? The first category is called data for judgment. You know it's data for judgment by its focus. Data for judgment focuses on individuals, not just individual physicians or nurses, but hospitals count as an individual in this too, or even a health system counts as an individual. Your purpose is to rank people or to separate the good from the bad, all right? They ask who's good versus who's bad. They stand in fairly sharp contrast to what are called learning systems. The fundamental difference with a learning system is rather than focusing on person, which surgeon is best, which surgeon is worst, it focuses on process. It assumes that the surgeons and their processes are separable. It assumes that people can change. This is actually the fundamental concept upon which all ideas of change rely. You see? Laying down underneath it all. So it focuses on process. It doesn't say who, it says why or what or how. Why do you do it that way, doctor? What would you do to accomplish the same? How do we achieve those goals? Those sorts of questions. It's much closer to a research system. Traditionally in research, this is where we usually focus along the way. Now, I want to just point out that judgment presents some very significant barriers. I know of 7 or 8 that I can identify in theory that I can track to actual failings in practice. I just want to focus on the top 2, all right, in the interest of time. We have other names for judgment systems. They're also known as selection systems. Your aim is to select the best. Very often it's explicit. We'll rank the physicians so that patients can know who's good, who's bad, and vote with their feet. We often argue that it will motivate the poor performers to improve. Another name for it's top-down, or Taylorism. The idea behind Taylorism is up here you have the smart people who rose to the top of the system. How do you move the smart people's thinking into the workers' hands down at the front line? So up here the thinkers, down here the people who can only do, you see? And then number 2, how do you ensure compliance with the instructions given? And finally, in this model, the front line is usually regarded as kind of malingerers. When Fred Taylor described it, he actually said hardly a competent workman can be found who does not devote a considerable part of his time to studying just how slow he can go and still convince his employer he's going at a good pace. That's a direct quote. So you have to motivate them. It might be reputational, where you drag the reputation through them at a negative consequence. It might be a financial incentive, you see. But we call that Taylorism or top-down management. It's also called focus on the tail, or outlier management is another name for it. The point, this approach, the top 2 problems, it provokes a very predictable response among human beings. And number 2, it contains a fundamental framing error in terms of how you're thinking. Yeah, the predictable response, my favorite description of it comes from a guy named Schirkenbach. I've got 7 or 8, all describing the same thing. He calls it cycle of fear. He says it's a fear-based system. I don't know. If I attack somebody with my QUE data, those initial data on TERP, how will those physicians react? Are they going to thank me for coming in and ranking them? No, they're going to push back hard. Initially, they're going to challenge my data. They're going to challenge my access to the data. You get an awful lot of shift the blame. Hey, it wasn't me. It's the guy who was on call. My patient didn't follow my instructions. Let's put the blame on the patient for a while. Wasn't me. In theory, I can overcome this administratively. I just roll over them. It will destroy my ability to lead change, but I could move ahead anyway. That just leads to number 2. Deming called it filter the data. I'd call it game the system. Turns out that the data we collect about these people, they generate it themselves, and it changes the data they report. In fact, Deming said that if you put pressure on somebody to hit a numeric goal, there are 3 ways they can do it. Improve the system takes time and work. You can teach to the test, where you focus all the resources under the spotlight, buff the numbers. It always comes at the expense of things that are not under the spotlight. I've got pretty good empiric studies showing that your overall performance declines. While you buff the numbers under the spotlight, we call it teach to the test. It sub-optimizes the system. The most common is game the data. Well, wait a minute. If I say it politely in a clinical setting, I would say improve your documentation. All right? Just to show you what happened in the United States, this is one among, I have a list of these. It's almost endless supply of examples. This is Greg Fonerow at UCLA. The United States Medicare Administration, part of the government, for elderly patients, they insure everyone, of course, universal insurance for over 65-year-olds. They established a measurement system around 4 conditions, 4 measures per condition. It's called CMS Hospital Compare. Then they ranked all the hospitals in the country. What we saw over the years, it's the left-hand graph, is that performance around those metrics improved dramatically. Everybody showed dramatic improvement in the metrics, all right? The metrics were actually selected because they were directly associated in the research literature with mortality rates. That's how they were chosen. And Fonerow points out with those dramatic shifts in performance nationally reported that there should have been equally dramatic changes in mortality rates. And then he laid up the mortality data side by side. Oh, that's the right-hand graph. What it's showing is no change in mortality. So dramatic changes in performance metrics, no change in the outcomes they were designed to affect. All right? What does that tell you is happening? Yeah. Turns out the response was uniformly game the data. Now, sometimes people go over the top with this. You get areas that are actively illegal. Most times you don't have to move to illegality. I could show you lots of examples in many different settings. Some of the more recent scandals we've had in the U.S., the whole VA waiting list scandal, if you heard about that up here, a classic example of exactly this. No Child Left Behind, that was our educational system driven from Washington, D.C., about testing of schools and school teachers. Atlanta was where the big scandal was, where some teachers were sent to prison for gaming the data system. We recently had a big scandal with Wells Fargo Bank where they'd put very aggressive goals to, sell multiple times to customers. And it ended up with the front line generating accounts for customers without the customers knowing, just in passing. It's an endless well of examples of this. It's completely predictable, all right? And it's a warning to watch out if your main measurement systems for quality are designed to rank the care providers. We usually call it accountability, but it has a completely predictable result every time. This is not an area where we lack data, guys. We've had experience with this in many, many different sectors, including healthcare on a very wide scale. And I've only shown you a superficial bit of it. Turns out, though, that it's not just the behaviors that kind of a focus provokes. There's a worse problem. We frame the problem wrong. We call it focus on the tail. So this is a real slide. The x-axis is a mortality rate, technically a risk-adjusted mortality rate measured by the U.S. government across 8 conditions. All right? It's a frequency distribution. The way I, as a statistician, think about data, the x-axis shows mortality rate. The y-axis shows how many hospitals in the U.S. achieved each rate. And what we've traditionally done in a focus on the tail, a bad apple, a judgment system, is we generate the metric, then somewhere along it we draw a line. It's that blue line. We often call it a standard. Technically, it's actually a threshold value. This is Evidencebased, who wrote the original kind of Bible on quality in healthcare from University of Michigan. Well, the idea, if I cross the threshold from the green out into the red, I think about and approach or treat those people differently. They're my outliers, aren't they? The belief is if you find and eliminate your egregious failures, that what's left is somehow excellent. That's the thought that drives behind this. So what do you think? If I chop off that tail, is what's left excellent? I've tried to illustrate it. I labeled 2 hospitals. There's area under the curve where hospital B sits. Somebody's performing that well. Then I carefully positioned Hospital A to be just barely inside the threshold. Now, nobody's going to publish their name in the newspaper, labeling them a high mortality outlier. That's exactly what happened with that CMS system that Cliff Bailey and Henry Krakauer ran. Every year, they'd publish that in the newspaper to help patients vote with their feet and to cause the poor performers to improve their care, right? Nobody's going to drag their reputation through the mud with that punishment system, you see. They're good enough, aren't they? But wait a minute. That's a dramatically higher mortality rate than we had today. People are dying, literally. It turns out, too, it'll cost more once you get the money side connected in. We're killing people at great expense. You see the framing issue? It means you're asking the wrong question. You're asking, am I good enough? As opposed to asking, am I the best I can be? And in our line of work, I'm sorry, but am I good enough is not an acceptable question, given the nature of the work that we perform. It's always a question of, are we the best we can be? Let me show you what really happens. It's a couple little graphs. I published these years ago. This is from the engineering quality literature. They said you really want to improve quality, you got to do two things. Eliminate inappropriate variation. Underline twice and read the word inappropriate. Some variation is entirely appropriate. You have to be able to tell them apart. And number two, document continuous improvement. Doctor, it's wonderful that you think that you're God's gift to humankind. Is there any data at all to support that? Any voices besides your own mother and yours? Yeah, well, when you do it, it looks a particular way. So let's take the first case, traditional judgment system, focus on the tail, bad apple. So what I have here to the left is a frequency distribution, just as we showed before. Oh, my overall quality is the center of the distribution, that black line in the center. All right? Well, what I do is I establish a measurement system. I identify the bad guys down there to the far right where it says worse. I focus all of my time and attention for quality on that tail. Imagine, for the sake of argument, that it works. This is to put the best possible spin on it. Imagine that it works perfectly. Now, anybody who's worked in this field knows that that's amazingly naive. No, you're not going to eliminate the tail. You're going to settle in for 5 years of fighting about who's to blame. Cycle of fear is going to kick in with a vengeance, and you're going to get to spend your time arguing about who's to blame and whether the data are accurate. I've lived it. I've done it. Some of you have too, you see. But to put the best possible face on it, imagine it was perfectly successful. Well, to the right-hand side after, it shows the same distribution with the tail gone. How much does that improve my overall quality? I've tried to illustrate it, the new center of the new distribution without the tails, that dashed green line. I've actually had to overemphasize it a bit. It's a little too far to the left. The trouble is if I put it where it really belongs, it's really hard to tell that they're two separate lines. The right way to think about it, the area between the dashed green line and the black line at the center of the graph on the right there, up to the curve, has to equal the area under the tail, statistically. But I would get a small improvement in quality. Well, wait a minute. What if, instead of focusing on the tail going after the bad guys, what if instead I tried to, number one, eliminate inappropriate variation? What's that going to do? It's going to narrow the distribution. It's going to become much more narrow, tall, like a peak, all right? When I document continuous improvement, I take the same resources but apply them to all the players in the graph and try to slide everybody up to the left. This is what that one looks like. I've narrowed the variation, so I've got a narrower distribution, and I've slid everybody up to best performance. I want you to compare the distance between the dashed green line and the center black line on that graph compared to this one. Now you need to know, I didn't put them in the slide deck. I've got lots of examples of real case studies showing exactly that happening. Judgment systems are for idiots who like to spend their time fighting with people about who's to blame. I mean, it's a fun position. You get to be godlike in your powers. You get to separate the sheep from the goats and, send the goats to eternal damnation, basically. You get to feel amazingly self-righteous. But the fact is that at a purely pragmatic level, it is massively ineffective for driving change, good change, for your patients. Will you occasionally have a true outlier? You do. Given the nature of the healing professions, I jokingly say that we're really good at weeding out the sociopaths. Someone who is willing to purposefully harm a patient for personal gain, knowingly do so, is a sociopath. But we select for a very different mindset. We train to it. We reinforce it across your careers. I have to tell you that in 30 years of doing this in Utah, on a broad scale, 5 or 6 people. Now, when they occur, you do have to respond, but they're rare. You ought to be spending 98 or 99% of your time finding and implementing the best. As a real quality leader, 1 or 2%, you do need to respond if you do find a true outlier, all right? But they're rare. We're really good at weeding out the sociopaths in the healing professions, and when we find one, it's kind of a team effort. We respond. We tend to really respond. Do you see the idea? It's easier to call people into the light than try to whip them from the darkness. Positive reinforcement we learn from the behavioral theory literature is about an order of magnitude more effective than punishment in driving behavioral change. And this reflects that in many, many different ways. All right? If you're going to be successful, it's all about being best, not finding the bad. You'll have to do a bit of both. But know where your highest leverage comes. It's the servant leader, not the autocrat. It's how this shows up. Well, I need to quickly mention one other thing. That same literature, the variation literature, led us down a particular research path. We know why those problems that I listed earlier occur, that list of 5 of geographic variation, inappropriate care, patient safety, inability to execute consistently, and waste. I won't go into the details of it in the interest of time. I really don't have time. But we know how to fix them. The fix that emerged centers around clinical uncertainty. The cause was uncertainty in best practice. It transitioned over time. Think of it as 100 years of science. David Eddy is a fellow at Stanford University who invented the term evidence-based medicine and most of the formal methods we use for it. Now, David Sackett, a Canadian physician practicing mostly in Great Britain, popularized it broadly, he and others. Probably a more important role, but the theoretician who put it all together was Eddy. David Eddy said it in a very telling way. He says, the complexity of modern medicine exceeds the capacity of the unaided expert mind. Truer thing was never said. It happens in today's complex science-driven environment when we rely primarily on human memory as a means of delivering care. All right, I won't go through the details of this, but it's pretty much a well-established scientific fact. Starting with Eddy. We've found 2 methods for managing complexity in the history of humankind. The first is subspecialization. I want to focus your attention, though, on number 2. It's called mass customization. They're complementary. They work together. Now, lean quality theory, when Womack published his book in 1990, The Machine That Changed the World, he claimed that Toyota and the Toyota production system had invented this. That is not true. I learned it practicing surgery while being trained in surgery in the 70s. I was trained that when I did a case, I needed to do it the same way every time. What in the jargon of quality I'd call standard work, and I did. Made me faster. It's not just efficiency, that's anesthesia exposure time. We took a lot of pride in how fast we were to do it correctly and fast, you see. More than that, in a complex operation, I can build memory into the workflow. If I'm at this point of the operation, then this is what we do next. And it's a very potent tool for dealing with complexity. You build the memory into the workflow. Well, wait a minute. Every patient I saw was slightly different. If I were in any of your peritoneums, you would have small anatomic differences. Wait a minute. Sometimes dramatically large. Any surgeon knows this. You live it every day. Do I have to adjust to every individual? Yeah. It turns out mass customization is built around a funny little conundrum. The key to effective variation is standardization. So you standardize your approach, and then you vary for every individual, unique individual who comes to you. Hey, I was taught in that in the 70s. I watched my colleagues in the ED working up chest pain, same method. I watched a family medicine doc caring for diabetics, same method. You'll have a standard approach that you vary for individuals. So Lean claims it invented this. This is the core idea in Lean, just in passing. I can track it back at least 70 years within the healing professions. John Eisenberg, famous physician at Johns Hopkins says at least 200. John used to argue, this is not a new idea to clinical medicine, guys. We just didn't put a fancy term on it and then try to sell it as a consulting service to everybody else in the world. All right? There's nothing new here. Oh, wait. One idea that is new. When I was practicing surgery, I was with 8 other people on that same surgical floor, independent physicians. When I did a case, I expected the nurses to do it my way. I expected the OR team to do it my way. The house staff, the residents, my way. Oh, you administrators, you don't even get a voice. Just shut up and get me the resources. You don't know enough to even have an opinion. Please don't disturb me with your chatter. You've probably met other surgeons like this, haven't you? Yeah, I was in that category. Yeah. What if in a shared clinical environment we're all sharing the same resources? What if we come together as a group of professionals and establish a single shared baseline approach around which we vary? That's what emerged. I won't take you through the research that led to it. We call them shared baseline protocols. They're a very strong form of lean. Basically, you identify a high-priority clinical process, you build an evidence-based best practice protocol around it. Now, by definition, these protocols, I haven't taken you through it, they're always imperfect. They never perfectly fit any patient. The evidence is strong. There are a few rare exceptions, but they're quite rare. I can't write a protocol that perfectly fits any patient. It doesn't make sense to ask people to approve it. Why would you approve something that by definition is imperfect? So when we're working on one of these, I don't ask for approval ever. That's a silly idea. What I say is, what would you change to make it better? When you do that politically, you're making it so that a subset of your group can't veto any progress. It's a political strategy, actually, to ensure fairly rapid progress. And it really works. Now, steps 3 and 4 are the hard steps. You blend it into clinical workflow so that it doesn't rely on human memory. We used a series of tools. Standing order sets was the first, what we call clinical flow sheets, patient worksheets. Had about 20 little tools. Initially, we'd do them on paper, but eventually we'd move it into the electronic medical record. This is the primary role for purchasing electronic medical record, is this specific function. Clinical decision support to manage care at the front line under control of the clinicians who are actually doing the work. All right, I realize Epic, your Connect Care isn't ideally designed for that, but as the crop that you have available, it's as good as any. It's a decent choice, all right? But this is how you need to use it. If you fail to do this, you will fail to realize 70% of the value of your investment in that EMR. No kidding. All right? This is how you think about the thing. But you blend it in so it doesn't rely on memory. Hey, doctor, phone it in. Be absolutely lazy. Don't even show up. On full automatic, you're going to get evidence-based best care for these cases. See that idea? Now, in parallel, step 4, you have to embed a data system. It's going to track 2 categories of data. The first is variation. Anytime somebody varies from protocol, that's going to pop up next. It's the most efficient variation measurement ever found. It's cheap, it's easy, and holy cow, it's detailed. So drop an order, cross out an order on that standing order set, that's a variation. Add another order, that's a variation. Hey, the clinical flow says next I should go here and do that, and I say, nope, not for this patient, not today, we're going to go there and do that. That's a variation. You need to track the fact that a variation occurred as part of your EMR. And then side by side with it, I have to know what happened to the patient. So technically, intermediate and final clinical and cost outcomes. We can fill in the details on that later if we care to. All right? So those are the 2 hard steps. You blend it into workflow. Step 5 is the interesting one. The way I used to say it to my colleagues in Utah, ladies and gentlemen, it's not just that we allow or even that we encourage, we demand that you vary from protocol based on individual patient need. I have strong evidence that none of our protocols ever perfectly fit any patient and doctor. That's why we have you. I need a thinking mind at the interface. This is not an excuse to stop practicing medicine. In fact, what it does is take your most important resource, that trained expert mind, and allows it to focus on a relatively narrow band of questions where you have maximum impact, frankly, the fun part of medicine. I have to tell you, if you try this in your clinical practice, it's a little bit addictive. It's a wonderful way to practice. You'll never go back once you get the feel for this. Then lastly, it's that step 6. You build it's called a learning loop, a feedback loop. You focus on areas where people varied. You have an organizational structure, a team of people. Just to give you a feel for it, we first tried this on acute respiratory distress syndrome, ventilator management of ARDS. In its first 4 months of operations, we ended up putting more than 125 changes into the guideline. Todd Allen, Terry Clemmer did this for sepsis, got the whole sepsis effort going for the world. From LDS Hospital, all right, starting in about 2000. And they were slower than Allen. He took about 4 months to tune. They took about 4 years, but put over 100 changes in. I built more than 100 of these. And what you learn is there's a difference between being in a conference room and being at a patient's bedside in the real world. There's a difference between theory and reality. Deming called that fundamental knowledge. I have to have a mechanism to tune my theory to reality. And this is the mechanism. So I don't care if my protocol is imperfect when I start. It just has to kind of be in the general range, right? And then you start that feedback loop. It's a homing missile. And over time, it will tune you to best care with validated outcomes. By the way, when we did this with ARDS, it was in a trial. It was ECMO entry criteria patients. We had a 9.5% survival rate. When we used this, survival increased to 44%. First time since the ARDS had been defined as a syndrome in the 60s that anybody had shown an improvement in clinical outcomes, and it was dramatic. Fundamentally changed the nature of that disease. Costs fell by about 25%. By that point, we expected that. Deming's math proved it. About a 25% fall from about $160,000 per case to about $120,000 per case. See the idea? So the takeaway, guys, in our line of work, we really do count our successes in lives. The evidence is overwhelming. We could be dramatically better for our patients in their hour of need, unquestionably. That's the first big takeaway you need to hear. In Utah, I could document more than 2,000 lives per year of people who a few years ago, this was across a population that we were serving about 2 million people. People who would have died a few years ago who don't today. And these were not loosey-goosey population level studies, frankly. These were trials at a detailed clinical level where you had something you could really put a stake in the ground. We could be dramatically better for our patients. And you all understand, as I do, mortality is just the tip of the iceberg. Dramatically bigger impacts in terms of suffering averted, function restored. The second thing, it's associated with dramatic drops in cost. Just to give you a feel for it, across a 4-year time period at Intermountain, we took 13% out of our costs of operations, over $680 million. By the way, when I model the waste in the system, I get about 65%. 13% is a pretty good start. All right? I didn't do this analysis, the finance department did, so it was trustworthy. You do understand. I personally think I'm a far better analyst. It's that Harvard-trained biostatistician thing. But of course, I wasn't a member of their tribe, and they didn't trust me by definition. They thought I could torture the data and make it say anything I wanted it to. So it was important that their people did it. And it wasn't all of the improvement. We'd left out some major improvement projects at the same time. This is real. From a financial perspective, it's just as real as it can be. But to do it, you got to get out of that judgment mindset. You got to give yourself enough lead time to start to invest in management of clinical care at the front line and use all of your tools to that purpose. We could be much better, and that's the message I'd like to leave you with. That's your job, that's your duty. When I come back, I just want to see your success, as I'm sure I will. I've already seen quite a number up here. With that, thanks for your time and attention. Back to you, Francois. Time for a couple of questions.
Thanks to stay here, Brent.
Okay.
Try to stay. So thank you very much, Brent, for the very compelling presentation. And I think what we'll do is we'll go to the Q&A right away. For those who wants to send their questions via email, use pss@ahs.ca. So we'll start with a question in the room. Dr. Viner.
So you talked about the importance of making it easy to do the right thing in terms of having care providers do the right thing. Just a comment on pay for performance of physicians, and I was going to say in Canada we have different systems, but the American experience, if there's any benefit to that.
Studied this for years. I've come to, well, have you ever read Dan Pink's book, Drive? he summarizes evidence mostly from the business literature. It's not as rigorous as ours, but it's still compelling. He divides the world into two categories of activities. The first he calls algorithmic. An algorithmic task you can completely predefine. It's just a matter of executing against a fixed plan. Heuristic tasks, on the other hand, require adaptation on the fly, creativity and adaptation. All right? A very strong marker of whether you're dealing with algorithmic versus heuristic is education level. If you're a very highly educated workforce, it almost certainly means you're heuristic. In fact, I believe that healthcare at scale is the most highly educated workforce on the planet. Our tasks are massively heuristic. That's what I'm saying when you have to adapt to every patient. That's what I'm really saying. What the evidence shows is if you have an algorithmic task, financial incentives work as predicted. Reward or punishment, pay more, you get more, pay less, you get less, right? As soon as a task becomes even marginally heuristic, financial incentives consistently and actively damage performance. It's a strong finding across many different fields. The evidence is robust, all right? What comes into play instead is three factors. In a heuristic environment, you first of all have to have autonomy, self-directed. You have to be able to do that to adjust the protocols to individuals, don't you? So it's a functionally critical element. Next is mastery, this ethic of personal excellence that drives good professionals everywhere, good clinicians. So we don't want to lose that at all. And lastly, purpose-driven. He shows so many examples of people who invest heavily, even when they're not paid, for things that make a difference to humankind. Can you think of professions where the purpose-driven nature of our work is greater than ours? We make real differences in human lives. So the way to think about it is not incentives. Think about it as autonomy, mastery, and purpose. And by the way, we have beautiful examples of exactly that working and working well in healthcare. All right. By the way, the financial incentive approach is a classic judgment-based approach. Just in passing.
We have a question by email.
So we actually have a question from our president and CEO, Dr. Bernie Huhn.
Oh.
She said, great talk. Can you please expand your financial comment of the 13% reduction?
Yeah.
How does that translate in hard green dollars as opposed to cost avoidance?
Well, so this is a complex question in the following sense. It depends on how you're paid and budgeted. I have any number of great examples from the Intermountain system where we clearly reduced the cost of operations. The question was, who got the money? And this is a question I plan to pose to your physician leadership groups later this afternoon. If I run a big improvement project and extract waste, who gets the money? So just to illustrate, I realize you believe that you're on a different payment system than we are down in the States. Oh, wait a minute, you still do use fee-for-service for your primary care physicians, don't you? Oh. Maybe it's not so different as it seems. Occasionally, I've even seen you use DRG-type systems per case payment. So we have more commonalities than we might think across the way. Yeah, it happened for me first up here in Canada, in Vancouver. I was working with a hospital administrator over in Vancouver. He ran 3 big improvement projects, saved about $2 million Canadian. Now, this was a few years ago. It'd be more money today. What happened is his political leadership took the money he'd saved, reduced his budgets going forward to reflect that savings, took that money and then gave it to some of the struggling hospitals who had needs. And he said, I now don't have the budget, I don't have the resources to do it again. He said, I'm never going to do this again. That's what he said. So one of the things you learn, and I've got lots of examples of it from my side of the line, down in the States, my side of the border. How do you line it up so that when somebody improves, you have to, it always takes investment. You need to be able to recoup that investment, and you need enough for seed money for the next one. And it has to do with setting strong visions about our primary purposes, right? We'd really like our services to be more widely accessible to the people we serve. To do that, your care needs to be affordable. I look at the queuing that happens up here in Canada as an economic measure. It's how I really look at it, you see. How would I build a system if you reduce your queues? So what will happen is, as you do an improvement project, about half of the actual savings will show up as unused capacity. And that unused capacity means that then you can work down queues. So it shows up as queuing time. How do I work that into a not perfect but comprehensive budget so that we're on the same page, we're on the same vision of taking waste out of the system to make our services generally affordable? I can't kill the goose that lays the golden egg. Right? I want more geese that lay more golden eggs. That's what I want. And I believe, in truth, that this lies at the level of leadership. I could share lots of examples from within my old system where exactly this happened, where a local department would take a hit in their budget. They lose $100,000 and we make $2 million. Really? But it happened in somebody else's budget. And the people within the departments can't manage that. It takes somebody higher than them in the hierarchy to see that balance. It's called sub-optimization technically in the theory. So that's a way of thinking about it. But you do have to address that, guys. And your problems are just as bad as mine at this level.
So we're going to unfortunately have to close off, but would like to thank Dr. James for coming today and really appreciate you coming. And this presentation is videotaped and will be on Insight under President Speaker Series, so it's accessible to all of you. And I'm sure hopefully you will use it. Thank you very much. And I know that you spent quite a bit of time in Alberta. In fact, some of your colleagues in the U.S. thought you had a Canadian accent, so we're really pleased about that. We're actually really pleased about that.
That's really true.
We'd like to offer you a small memento for
Thank you.
doing this
Thank you,
series. Thank you
Francois.
very much. Really
Thank you
appreciate
very
it.
Just as we wrap up, what actually happens is I grew up in southeastern Idaho ranching cattle. And we were part of a larger community that extends up into southern Alberta. A lot of intermarriage across that line, and there was no border, guys. And so I have been accused routinely, regularly through the years of having a Canadian accent, but I'm almost sure that's where it comes from.